So I'm going to go ahead and introduce Dr. BouHaidar, who is, I'm sure, known to many of you and is Associate Director of Medicine in the GI Division, where he really leads the charge as the Director of Therapeutic Endoscopy. And I think that will be one of the updates that he's going to give us today. Dr. BouHaidar has really been, a major leader in our programs in advanced endoscopy and been responsible for training many of our fellows in GI, and really has very high national level expertise in these areas, and provides great service not just to our patients, but has also provided service to national organizations in GI leadership as well as education. And we're really very lucky to have him on the faculty, and just a unique skill set, a very busy clinician. And it's really a pleasure to introduce you to today's Grand Rounds, and we really look forward to your update on ultrasound and endoscopy. And we'll have Dr. Sanyal if he makes it finish up, but we are excited to have you here and very grateful for your service to the department and the institution.
Thank you, Dr. Stein. Thank you for inviting me. Can you guys hear me okay?
Yep, we can hear you great. Thank you.
All right, perfect. So again, thank you for this invitation. And my topic is going to be about endoscopic ultrasound. And I'm sure all of you are aware of this technology that we have. I just want to update you on the myriads of indication that has emerged over the past several years. So the first part of the talk is going to be like an overview, and then a little bit more about the new thing that we're doing with EUS that some of you may not be aware. So there are two types of EUS scopes. One, we have a radial EUS scope that is like a regular EGD scope with a balloon on the tip and a transducer, and it image in a perpendicular to the long axis of the scope. So as you can see, it scans like a CT scan as it goes down. With this scope, you get it's called Diagnostic EUS, so we can do anything therapeutic, but gives us a great images, especially in the esophagus or in the rectum. Now, the other scope that we have is a linear EUS. It scans in a different way, and it allows the needle to come out and stays in the sector of the endoscopic ultrasound array, so we can target and do either biopsies or therapeutic procedure through that. So that's our workhorse scope that we have. So those are the two type of scopes that we have. And there are indications for EUS. It can be diagnostic and it can be therapeutic. And as I mentioned, I'll mention briefly about the diagnostic indications that has been established over the years. Again, this technology started in the 90s, like mid-90s. And it was a technology that was trying to find indications for itself. And I remember my mentor at that time saying, oh, this is like, because you can do EUS, it doesn't mean that it's going to fly or it's going to be an important arsenal or a tool in our arsenal to treat patients. And little we know that maybe 15, 20 years later, now it's an essential tool that we have to treat different diseases. So there is a diagnostic portion and there is a therapy. So for the diagnostic, it is again essential for esophageal and rectal, a little bit less for pancreatic. Also, it's important in the lung and gastric. It is less and less important in the staging of the cancer. And then also we can use this tool to check for coridocolithiasis, especially when they are located in the distal common bile duct. That can be the most sensitive way of detecting small stones in the distal CBD. And that's usually even when MRI fails to show the stone, EUS can be more sensitive to small stones in the distal CBD. It can also be useful in identifying subepithelial lesions and trying to categorize them. Bile duct stricture, if they are indeterminate stricture, we can see if they look malignant or not and maybe take biopsies from them. We can also use it for pancreatic cyst evaluation, pancreatic duct strictures. We can also assess chronic pancreatitis changes, even when they are like years before CT scan or MRI shows those features, it can be the early tool to detect very early changes of chronic pancreatitis. It is also a useful tool to detect mediastinal lesion and or localization of neuroendocrine tumors. Now, in terms of therapy, again, the list keeps on growing, and that's one of a few of the things that the EUS can do. One is a pseudocyst drainage, celiac plexus neurolysis, fiducial placement. It can help with access in difficult pancreaticobiliary cases, especially if the ampulla is unreachable. It has proven to be a good tool to do ERCP or help in an ERCP in gastric bypass patients. Is called the EDGE procedure, which is endoscopic ultrasound directed transgastric ERCP. So obviously they were in trying to be inventive in this with the name or the acronym for this procedure, it's EDGE procedure. And then pancreatic cyst ablation has been tried and still being tried, and also in cancer therapy. So let's start with the diagnostic indications for the EUS. The first one, this is how a normal esophagus looks like. So you can see all the layers. You can see the mucosa, and then you can see the muscularis mucosa. So the first bright layer here is the first layer, which is the mucosa. Then the dark layer, the first dark layer, that's muscularis mucosa. Then you have the submucosa, muscularis propria, and then in the esophagus, you have the adventitia. But further down in the GI tract, it will be the serosa. So you can see bright, dark, bright, dark, bright. So those are the layers that when we stage cancer, we just have to look carefully and see if that cancer is invading which layer and goes beyond which layer. So for example, in esophageal cancer, it is the best modality for TNM staging or TN staging, and it can be accurate up to 90% of the time. So what are these stages? They are T1 when it invades the submucosa, T2 when it invades the muscularis propria, and then T3 when it invades the adventitia, and then T4 when it invades the surrounding structure or adjacent structures. So these are examples of how EUS will look like. So this is tumor invading the submucosa, and then you can see that the muscularis propria is intact right here. That's the dark layer. So it invades the first dark layer, goes into submucosa, but does not even touch the muscularis propria, which is it makes this lesion to be a T1 lesion. T2 lesion, it goes and invades the muscularis propria, which but does not go beyond. So it does not go to the adventitia. In this case, you can see that the adventitia is completely gone, and you can see tumor extending outside. I'm not sure whether the pictures are transferring properly or not. I hope they are. But you can see like this side of the esophagus, you can see all the layers clearly, and suddenly you lose that layer here, and then things are protruding outside that muscularis propria, so making it a T3 lesion. And then in this case, and again, it's a little bit dark on this image, but you can see tumor here that looks hypoechoic. All this is tumor. And then this is aorta that looks also dark, anechoic lesion. And if you put Doppler, you can see Doppler in it. And then right here, you see a loss of interface. And that's an important tool to give to the surgeon, because the surgeon doesn't want to go in and open a mediastinum just to find out that he cannot peel off the tumor from the aorta, because if you create a hole in the aorta, that's a big, obviously the patient will die on the table almost immediately. So those cases when there is a loss of interface, the surgeons definitely would want to give chemoradiation first to shrink the tumor, let the tumor kind of pull away from the aorta before they even attempt to do surgery. So as you can see, it's a very important tool in TNM staging. It is also useful in end staging. Whether you do biopsy or not, there are criteria that you look at to make this lesion or this lymph node to be more malignant. So one decides if it is more than 10 millimeter, then if it is a round shape versus oblong shape, and if it is hypoechoic with a smooth borders. So all these features, if they are present, makes this lymph node, even without biopsy, you can tell it's malignant. So this is a tumor in this image right here, and you can see multiple lymph nodes that looks malignant. And you can see that it is, when you combine EUS with FNA, obviously you increase your sensitivity to 86%. And if you do just PET CT scan and you rely on the PET CT scan, it's only 44% sensitive in telling you whether this lymph node is involved with cancer or not. Now, what are the limitations in esophageal cancer staging? One, a lot of time, by the time a tumor becomes symptomatic, usually the lumen is very narrow to the point where sometimes it's very difficult to pass even in the EGD scope across. So if you're scanning from the upper end or upper edge of the tumor and you're not right in the midst of the tumor just because you can't cross it, then you may be understaging. Another potential drawback is if you have a lymph node that maybe looks malignant, maybe not, and you want a biopsy, most of those lymph nodes are locoregional, meaning that they are right in the, the tumor may be in the path of the needle, and you really don't want to stick a needle across the tumor to get in the lymph node because that can give you a false positive, and you can seed a potentially negative lymph node and make it positive by spreading the tumor outside the esophageal lumen. So these are the limitations. How about gastric cancer? Again, in the past, people relied a lot on EUS. However, with advancement on CT scan, it is not used as much for large pancreatic cancer. So we don't, if you have a gastric cancer that is big, you rely on CT scan more than anything because most of those cases, they will require surgery regardless of the stage. However, it's very useful when you have a lesion that is, high-grade dysplasia or carcinoma in situ, and you want to see if you want to, do EMR or ESD. So if it is a T1, T2 lesion, you may be able, T1 lesion mainly, basically, not T2, but you may be able to remove it by ESD and cure the patient that way. So it has a role in that setting. But in terms of like large tumor that are visible on CT scan, it has limited role in staging. How about pancreatic cancer? When you combine it, one of the big advantage, obviously, not only we can scan and mention the staging of the tumor, but we can take biopsy. And the majority of the time we are asked to take biopsy. And it increases sensitivity to 85% with specificity of 98%. And if you do CT guided biopsy, first, they have issues that not all pancreatic tumors are accessible by CT scan. They can be, a way they have to go either through liver sometimes or through colon or through stomach to get to the lesion, making it a little bit more complicated for CT guided FNA. So we can do wherever the tumor is in the pancreas, we should be able to reach it by EUS and take some biopsy and stage the tumor as well. And new needles have emerged over the past several years that allows us even to take a core biopsy and take a big chunk of tissue, or it's not big, but bigger than just cytology samples that we used to get with a tiny needle. So there are different type of needles that are on the market right now that can provide us with a core tissue biopsy of the pancreas. So for staging, EUS has a limitation and it's superior in certain degrees. So one, it is superior in detecting small tumors. There are many lesions, for example, let's say neuroendocrine tumor that are secreting, sometimes can be missed by MRI, but if they are less than 1 centimeter, they can be very evident on EUS. It also is a great tool to detect portal vein invasion. When you compare it to CT MRI, is a bit better than NCT MRI. However, it is not as good to detect SMA and SMV involvement because those vessels, they can go into our blind spot when we do EUS. So again, with the advancement of CT, high resolution CT scan and MRI, surgeons do request CT and MRI to stage pancreatic tumor, and they don't rely just on EUS as staging. But if any of those modalities shows invasion into a vessel, they are usually superior to the other modalities. So as you can see, we can detect invasion that are not detected by the other ones, and they can detect invasion that are not detected by us. How about cancer of the rectum, rectal cancer? Again, the same as esophageal tumor. It can be like a great tool for T&M staging. And why do we need to do it? Because again, if it is anything beyond T1, T2 lesion, anything beyond T3, T4, anything is T3, T4 or N1 tumor, giving neoadjuvant therapy decrease the chance of recurrence of rectal cancer. So for those cancer, you want to give them neoadjuvant tumor if you prove that they are T3 or T4 or even N1, because again, the outcome is better. So you don't go to surgery, you go to neoadjuvant therapy first, even for small tumor. So that's the real reason why rectal EUS staging is still an important tool, because again of that, it detects the patient that will benefit from neoadjuvant therapy before surgery. The sensitivity and specificity is really good for the T&M, similar to the esophageal staging. How about diagnosing Coridocolithiasis? Now, again, we don't use it as a primary tool. It's an invasive procedure. It requires sedation. So obviously, if you have endoscopic, so when you look at the modalities, we have different modalities. We have the CT scan, we have right upper quadrant ultrasound, we have MRI, MRCP. Now, between those modalities, the best modality to detect gallstones is still right upper quadrant ultrasound, transcutaneous right upper quadrant ultrasound. It is still the most sensitive and specific tool that we have to detect gallstones in the gallbladder. Now, when it comes to common bile duct, in the proximal part of the common bile duct, MRCP have an edge. CT scan does not have a great role in detecting common bile duct stones. If you see it, that's great, you know it's there. If you don't see it, it does not exclude it. So MRCP, especially for proximal stones, it is very sensitive and specific. Where EUS has an edge is in the distal common bile duct and in a small stone. So if you have a distal common bile duct, high suspicion for a stone and MRCP is negative, and you still have a suspicion that there is an obstructing stone, then you have to go for EUS. If you don't want to do ERCP right away, a lot of time, you guys see us schedule patients for EUS/ERCP specifically for that reason. We go in, if we see a stone, we proceed with an ERCP. If we don't see a stone, then the stone has passed and we're done. So it has a great role in detecting even small, tiny stones and fragments in the distal CVD. As you can see in this image, this is common bile duct that is dilated. This is a cystic duct. And then this is toward the head of the pancreas. And this is an image where you see a stone with shadowing, similar to what transcutaneous right upper quadrant ultrasound will show the stone. But we are very sensitive. The EUS is very sensitive and specific for stones in the distal CVD. How about evaluation of chronic pancreatitis? As mentioned earlier, I did mention it briefly earlier, that it can detect early chronic pancreatitis changes. I just want to look at the time, make sure I'm still good at timing. Okay. So it can detect early chronic pancreatitis changes years before MRI and CT scan. So obviously, if you see on CT scan some calcification, which are, by the way, a better tool to detect calcification compared to MRI, also EUS is better than MRI to detect calcification. So if you see calcification in any modality, that's it, you're done. You have chronic pancreatitis. However, there are some changes that appears by EUS before CT or MRI changes appear. And there are multiple criteria we look at. There are parenchymal changes and there are ductal changes that we look at. And we divide them into major and minor. This is how a normal pancreas will look like. It's salt and pepper appearance and it's homogeneous. And you can see the edges or where the edge of that pancreas is. And this is an image showing lobularity at the edges of the pancreas. That's also a sign of early chronic pancreatitis. You can see calcification with shadowing. You can see cystic lesions or cyst or dilation of the pancreatic ducts or side branches. You can see stranding around the pancreas, and you can see the duct that is quite dilated and ectatic. This is main pancreatic duct. There is a little bit of pancreatic atrophy, and you can see the dilated duct, which is this kind of dark structure, linear structure in that area here. How about subepithelial lesions? Well, there are subepithelial lesions can be two things. So when you scope somebody and you see a submucosal mass, it can be two things. One, it can be intramural within the wall of the lumen or within the wall of the stomach or esophagus or colon. And it can be extramural, meaning that something else is pressing on the lumen, giving the impression that there is something in the wall. So EUS certainly can detect that. And by appearance, you can tell what it is. So if it is hyperechoic, it's usually lipoma. Nothing much will look like hyperechoic, like this, homogeneous, other than lipoma. If it is hypoechoic, it can be different things. It can be gastrointestinal stromal tumor, carcinoid, or leiomyoma. If it is anechoic, it can be vascular lesion or a cystic lesion. If you put Doppler, you will be able to identify which one it is. Is it vascular or cystic? If basically with the Doppler available on both radial and linear EUSs that we have in our arsenal. So this is an example of an intramural lesion where you can see the layers, and this is in the submucosa, and then you can see it's very bright, and it is hyperechoic. That's a lipoma. This is a gastrointestinal stromal tumor, and you can see it's originating from the fourth layer here, which is the muscularis propria, and you can see hypoechoic lesion here. All right, moving on to pancreatic cysts. There are different types of cysts. There are mucinous cysts. They can be mucinous cyst adenoma or mucinous cyst adenocarcinoma. Obviously, I alluded to that mucinous cysts have the potential to develop cancer. Serous cysts, however, they are benign and they remain benign. They may grow slowly over time, but they will remain benign, and the chance of malignancy is extremely low. And there is a in the mucinous cyst part, and a lot of you can see IPMN, and IPMN means intraductal papillary mucinous neoplasm, and it can be a branch IPMN, which means it's attached to a branch of the side branches of the pancreatic ducts, or it can be main branch IPMN, which means that the entire main duct is dilated and is mucinous. And the other one can be inflammatory or pseudocyst from leakage of, from chronic pancreatitis or acute pancreatitis attacks. So EUS has a role because by looking at the EUS images and by doing fluid cyst analysis, we can tell what this lesion most likely is. And the main thing that we look at tumor markers, which is a CEA. and we look at amylase level. We can also look at cytology, and we can look whether there is a mucinous component or non-mucinous component. And there are studies that looked at DNA analysis of that fluid. However, I will tell you most of it, amylase, CA level, and cytology are the key components that will give us a big idea where to categorize this lesion. For example, if it is a pseudocyst, you would expect amylase level to be in the thousands, and you expect the CA level to be almost non-existing, 0. So that tells you, with a little bit of history of chronic pancreatitis or acute pancreatitis in the past, that immediately puts it into a pseudocyst category. If it is a very high CA level, like more than 1,000, for example, and the low amylase level, that puts it in the category of even a mucinous cyst, even a mucinous cyst adenocarcinoma. So that's just giving you an example how, when we interpret those fluid analysis, how we can divide the different type of cysts into what they are. Okay. Now, that's the part on diagnostic. Now, the second part of my talk, and I think I will be good on time, will be about therapy. Any questions so far? I guess I'll continue on with the therapy part. First thing that we can do celiac plexus neurolysis, and we are one of different services provide that service. We're not the only service that provides celiac plexus neurolysis. They can do it under CT guidance, and we can do it under EUS guidance as well. So basically for us, it is very easy because we go and it's right at the GE junction area where you can actually identify the celiac axis. And again, we use in any therapy, we use the linear EUS where you can see the aorta. This is descending aorta. And the first vessel that comes out of the aorta, that's the celiac artery. And right in that groove, you have the celiac ganglia, and that's what we target. And what we inject bupivacaine first to numb that area, when we follow with either triamcinolone or alcohol for ablation. And again, we target the celiac ganglia to treat. Now, for chronic pancreatitis, it is 50-50 chance. So not everybody responds. A lot of it because the pain from chronic pancreatitis can be difficult because it has multiple pathways, and it's not really just by blocking the ganglia you will get results. And that's why we have only 50-50 chance of improving the pain. Not only that, it only lasts about 3 to 6 months, and that's if it is effective. So you have 50-50 chance of improving the pain score for those patients, and then it can only last 3 to 6 months, doesn't last too long. Now we have a little bit better response when we do it for pancreatic cancer pain, because if you have a pancreatic cancer that is invading the nerves around the pancreas or inside the pancreas, it can be quite painful, and blocking the celiac plexus has a good chance of responding or decreasing the pain or pain medication requirement. We can use EUS as well for to do ablation or RFA. There are RFA probes that can be so radio frequency ablation that can go through a 19 or 22 gauge needle, which are our needle that we use when we take biopsies. So we can stick a needle into the cyst and use the RFA probe and apply heat around the area that we need to treat. And we can do it for ablation of neuroendocrine tumor and pancreatic cyst neoplasm. You can also use it to inject therapies. None of it is mainstream, but this is to show you that over the years, it has been used and continue to be used in clinical studies to see if they are help as a neoadjuvant treatment for either cystic tumors or adenocarcinoma of the pancreas. This is an example of ablation of a pancreatic cyst. So a lot of people at the beginning try to, like, instead of like following up on those cysts by imaging and wait for them to grow, what about ablating them and removing them, or just, you know, blocking them from growing, ever growing? And people have used alcohol to ablate the lining of the cyst. And that's the idea of ablation with alcohol. The problem with alcohol ablation, it can cause pancreatitis. So either from leakage of the alcohol or just by the local inflammation that happens when you ablate the tumor with or the cyst with the pure alcohol. So for small cysts, again, we don't need to do anything. All we need to do is just follow them by cross-sectional images. And they are common cysts. They are found in many cases in the ER when they come for abdominal pain for other reasons. And you find those 1.5 centimeter lesions, and all you have to do is monitor them. You don't have to do anything other than monitor. You don't even have to do EUS. You just have to monitor, make sure they are not growing those cysts. Now, if they are high risk cysts, then you probably will refer them to surgery. And if they are not surgical candidate, this is when you start thinking about ablating those cysts with either alcohol, or in this case, they tried with chemotherapy agents to ablate those cysts. And the ablation efficacy, with this, for example, in this study, using paclitaxel and gemcitabine, the combination was more effective and less risky in developing it. So they had no cases of pancreatitis in those cases. Also, another thing that we can use EUS for is EUS guided coil and glue injection. This is a large gastric varix, and you can see here you put Doppler on it, and you can see that the varix is quite large, measuring 4 centimeter by 3 centimeter. And instead of like just putting glue, which is going to be a massive amount of glue, and the more glue you put, or the larger amount of glue, there is a risk of this glue going and embolize things. So in this case, what like we learned from IR, that we can actually put a coil, and similar to the coil that IR used, to kind of create a space occupying lesion and allow a little bit of clotting to form around that area. And we follow it by glue injection. Again, obviously, this is a risky procedure because if the patient is like starts to move, you have to do those cases under general anesthesia, because you can't allow the needle. Once you puncture that vessel, you cannot just let go without finishing the treatment of that varix. Otherwise, you will end up with a major bleed. And this is after the glue injection. As you can see, it clotted. When you put Doppler, you barely see any flow through that Doppler, I mean, into the vessel or the varix that was treated. And this is an example where you can see a little bit of one of the coil protruding out, but the vessel have been treated and it's completely, the risk of bleeding is non-existing anymore. You can also, and in studies where, we haven't done it here yet, but it can be used as a portal pressure measurements. And the advantage of it is at the same time, given that we have 4 biopsy needles, so one, you can do the portal pressure. At the same time, you can do a liver biopsy. You get 2 in 1. And this is one thing that we are looking to bring to our institution. But it's being ongoing in clinical trials in different places. All right, another therapy that EUS is useful for is pseudocyst drainage. Now, this has evolved over the years. So when I started my training back in the late 90s, EUS, the channel of the EUS was very, very small, and it would not allow anything therapeutic to be done through it. And a lot of time what we did with those cystic drainage, we looked at the bulge and we used an ERCP scope to puncture almost blindly into that bulge and then create a fistula between the stomach and the pseudocyst to drain it. Then EUS became available with larger channel, linear EUS became available. It became safer to do under EUS guided drainage, and it's still cumbersome because what we had to do, we had to go with a needle, you had to use a needle knife to kind of burrow through into the pseudocyst and then dilate the tract and then put 3 plastic stents that are 10 French each. 10 French are like divided by 3, which will be like 3.3 millimeter. And you have each time to cannulate next to the stent to make sure you are on the other side of the stomach into the pseudocyst to place 3 stents next to each other. So the procedure took very long, and it was like maybe 40 to 1 hour procedure time. However, with the advancement of the self-expanding metal stent, there is a stent that was invented mid 2015, around 2015. That stent is a lumen opposing metal stent. So it's called Axios with electrocautery enhanced stent. So basically it's like a needle that is a large needle. Stent is on the tip of that needle. All you need to do under endoscopic ultrasound guide is you don't even need fluoro for this. Apply heat right into, and it goes straight into the pseudocyst, and then you deploy the first flare of the stent, and then bring the stent a little bit closer and deploy the second half of the stent into the gastric wall. That's why it's called lumen opposing metal stent. So it brings the lumen of the pseudocyst and lumen of the stomach together and keep them attached to each other or close to each other to prevent any leakage of fluid into the peritoneum. So one, it became single step deployment, does not require a fluoro, and everything is done under endoscopic ultrasound. And this procedure, once you know how to do it, takes about 5 minutes, not more than 5 minutes to deploy the procedure. By the time you do the EGD, and sometimes can be a bit faster than an EGD, certainly faster than colonoscopy. So it is a very useful tool, and the other advantage, you remember I told you about like 10 French stents that are next to each other. Well, the lumen is going to be limited. With those stents, they are as wide as 2 centimeters in diameter. So certainly for, let's say, walled-off necrosis, where you have a lot of necrosis material, well, if you have a big hole connecting those two, it will allow a lot of junk and fluid and big tissue, or even you can drive a scope across and scoop some of that necrotic material out of that walled-off necrosis. So it had really created a huge step forward in the treatment of pseudocyst or walled-off necrosis in pancreas. And because of these lumen opposing metal stent, it can be applied anywhere. So anywhere a fluid collection that needs drainage can be reached by EUS, whether it's mediastinal abscesses, pancreatic collections, liver abscesses, gallbladder, and I'll show you a picture, a gallbladder, wide gallbladder, and pelvic abscess. All of those can be reached, and a lumen opposing metal stent can be deployed using the endoscopic ultrasound. This is an example of a large pseudocyst. As you can see here, the stomach is compressed, little bit of air in the stomach, and you can see it's very close to the stomach wall, and you can deploy a stent, and the technical success is 90%, morbidity is low, and complete resolution, it is up to 90%. Obviously, there are some recurrence rate, which is 10 to 15%. This is an example of the lumen opposing metal stent deployment. As you can see, the puncture first happened with using the the electrocautery enhancement, and then the first stent is deployed. The first part is deployed. You don't see it yet, but you will. There you go. So you can see the first part of the dumbbell-shaped stents is deployed. You bring it closer on the endoscopic ultrasound to the wall of the pseudocyst. And now here, you start seeing black here. That means that you have a stent in there. And you start deploying the second part of the stent into the stomach. Wait for it, and there you go. It opened up here. And as I said, here it looks like the lumen is very small, but actually the diameter of that, it's going to open even wider to the point where you can actually drive a scope across. So when you deploy it, it slowly, progressively dilate that tract in a safe way. Now, how about acute cholecystitis? Now, obviously, when you have acute cholecystitis, surgery is still the best option. But however, when surgery is not an option, let's say a very, very sick patient in the ICU that has acalculous cholecystitis cannot go to surgery, well, what do you do at that time? You ask IR to do a percutaneous cholecystostomy tube placement. Well, those, you probably, have seen it. They have, a high risk of complication, and you have to intervene again on those PTC, either by doing cholecystectomy later on, or keep doing something for that PTC drain, or not PTC, the percutaneous cholecystostomy tube placement. So there is a 50% chance of reintervention, 25% chance of complication. Well, we can do the same thing with the lumen opposing metal stent as a pseudocyst. You can see the gallbladder is inflamed. The wall is thick, little bit of fluid around the gallbladder, as you can see here. And then you go in, deploy the first part of the stent. That's the first part of the stent. And this is how, whether it's in the duodenum or in the stomach, you deploy the second part. So this is an example showing the comparing the two technologies, and EUS guided gallbladder drainage has a bit of an edge over percutaneous guided gallbladder drainage. It has less side effect, and then not only that, if it is a large LAMS that you placed or lumen opposing metal stent, you can go in and, if it is not acalculous cholecystitis, but calculous cholecystitis, you can go in and remove that stone through that tract that you created between the stomach and the gallbladder. I have two more things to tell you about. I'm getting close to my limited time. I'm gonna try to go quickly through them because they are important and they are new technologies or new things that we have done. One, it can be used as a failed biliary access if you have altered anatomy or you have malignant or biliary obstruction. So this is instead of doing a rendezvous with a radiologist and then they go through the liver or through the skin into the liver out into the bile duct, well, we can do our own rendezvous by going in, injecting and placing a wire into the duodenum. Then we go in and basically use that wire to do our ERCP. So it can be, we can do our own rendezvous procedure without using a radiologist. Another way, if you have a malignant obstruction and you just want to place a stent and you don't care about relieving or removing stone from the distal CVD, let's say there is a malignancy here, you can go straight from the duodenum into the common bile duct that is dilated above the ampulla or distal CVD or the tumor in the head of the pancreas and put a stent across, either from here or from here. So you can do it either way. This is to show that technical success ranges between 50% to 80% depending on the studies. I'm going to move a little bit quicker on this part. This is to show that even people thought about doing EUS as a first-line therapy for malignant biliary obstruction compared to try ERCP or try PTC. And it shows that they were very successful in the majority of those cases. You can use EUS to place fiducial markers. They are basically markers that are very visible by X-ray or by imaging, and it helps locating the tumor and speeding up the part where the radiotherapist will have to adjust the body correctly to start using radiation therapy. So a lot of time they ask us to place those fiducial markers, which are like gold probes, into the tumor itself. This is how the needle is injected. This is the fiducial, and basically, as you can see on CT scan, that tumor, the fiducial marker is very accurate in telling them exactly where they need to target. The last thing I want to mention, and that's why I moved a little bit quicker so I can talk about this part. It's the ERCP in altered anatomy patients. So it is the EDGE procedure, which is endoscopic ultrasound directed transgastric ERCP. So in this anatomy, so when you have gastric bypass, you have a Roux-en-Y, meaning that when you scope somebody, you go to a small gastric pouch, and that pouch connects to the jejunum, and it goes down all the way here, and that's the Y limb where it goes up into the biliary tract, right here where the common bile duct is, and then the excluded stomach. Well, people have tried, and we have done it here multiple times, where we did DBE, where we go through this, travel with the double balloon endoscope up into this until we see here, and do it that way, do the ERCP that way. But it's very cumbersome. It's only like 50–60% chance of succeeding or reaching that area. Even when you reach that area, you don't have the normal anatomy to look at, and you don't have all the arsenals, all the tools that works in a long scope channel to remove and be successful in doing the ERCP. So what were the alternative? The alternative was to ask the surgeon or IR to put a large bore PEG tube, allow this to heal, and then go through that large PEG tube, like take it out and then go through that hole and do the ERCP. Another alternative will be to ask the surgeon, take the patient to the OR, create the opening for us here, where in the OR we go in, do the ERCP, remove the stone, and come out, and then the surgeon close that hole. Well, the new way of doing this is because we have Lumen opposing metal stent. We go in, identify the excluded stomach by EUS, inject water to blow up the excluded stomach, and then deploy a stent. And whether it's a single day procedure or 2 or 3 days later, you go in through that stent into the duodenum, do your procedure, and come out. Whenever you're done, you take that stent out. Okay, so that's the EDGE procedure. We have done it here multiple times, and this is an example of how it's done. So again, you identify the excluded stomach. The key is to inject as much fluid as you can in the excluded stomach. We give them a little bit of glucagon to kind of allow the stomach to stagnate and allow the fluid to stay put. And then once we have enough space, we go in with a Lumen opposing metal stent or the axial stent, burrow through from the gastric pouch into that stomach. I'll move it a little bit faster. So that's the first part deployed. And then that's the second part. Now, if you want to do it single stage, you can dilate the tract. So, you do it single stage for patients who have cholangitis that you have no option to. The reason why we do it a few days later is we want a stent to dilate by itself, and we want stent to kind of stick together and decrease the chance of migration. Because if you deploy it right away and do the procedure right away, you can have it, the chance, or one of the complications that has been pointed or happened is a stent migration. And if a stent migrates, then you have a perforation, obviously, and the patient has to go to the OR. So most of the time, at least here at VCU, the way I've done it all in a 2-stage procedure. I would cool off the patient with antibiotics, do the first part, and then a few days later, go back in and do the ERCP part. This is an example of how we inject to see by fluoro where it is. I'm not gonna move forward quickly. So now, just to be on time, I'm gonna, the conclusions on EUS. So it evolved from a technology that was trying to find indications to become an essential tool in the gastroenterologist to make a difference in myriads of conditions. It is essential in esophageal and rectal cancer staging. It is essential in acquiring tissue and fluid from pancreatic lesions and other intramural and extramural lesions. The tissue acquisition and therapy options keeps on expanding, and pancreatic pseudocyst drainage and fiducial placement and solid tumors are well-established indication. And also, it is important to know that it is a operator dependent, and proper training is absolutely needed to have trusted results with excellent outcome. And the learning curve is a bit steeper than ERCP. So all our fellows learn ERCP a bit sooner than EUS. So EUS is a little bit foreign to our fellows when we train our advanced endoscopy fellows until like few months down the line, where they start picking it up and learn how to do it. And I will leave it at that. Thank you so much.
Thank you very much. Some great pictures there. As someone who's using endoscopy, that's an upgrade in pictures for me. So we'll open it up to any questions there might be. I know we're at time, but we've got time for 1 or 2 questions if people want. And if not, you certainly know where Dr. BouHaidar is, and I'm sure he'll be happy to answer really all the difficult ones offline. Well, thank you very much for that. Appreciate you taking the time. So we're a bit late in getting started there, and I appreciate all you do and complicated procedures that you do, and the
Thank you so
teaching
much.
that you provide to our learners. Thank you.
Thank you. Thank you so much. Have a good afternoon, everybody.